Here at Capcoder, we are delighted to introduce our new and revolutionary all-electric machine. Based on our best-selling Micro Mono, the Micro Mono E eliminates the need for compressed air to operate. And with options such as automatic bottle in-feed, integrated filling, and automatic cap placement, it makes the Micro Mono E unique in the industry. Ideally suited for ultra-clean rooms wanting to eliminate any potential contamination of compressed air, or areas where compressed air is not available. The Micro Mono E requires only a standard 13 amp plug to operate. The all-electric version still excels anywhere from small batch work to high output production. Capcoder are excited to demonstrate their bestseller, the Micro Mono benchtop filling and capping machine. With unparalleled ease of use, flexibility, and a multitude of configurations, from fully manual to fully automatic operation, the Micro Mono truly does stand in a league of its own. Using the same control system as our flagship monoblock, it allows us to incorporate sophisticated technology such as load cells, precision sensors, and torque transducers. It can be integrated with a number of different style fillers, and as well as standard capping, can accommodate styles such as trigger sprays, press-on, and even crimp capping. Originally designed for customers that have a frequent product changeover, the Micro Mono takes advantage of quick release tooling, meaning product changeover can take as little as 2 minutes.
Hello there, my name is Daniel Couch. I'm the medical lead at the Centre for Medicinal Cannabis UK. And today I am joined, I'm very grateful to be joined by Harry Guliani, who is the International Operations Lead for Columbia Care, a major medical cannabis producer and supplier. And also very grateful to have Dr. Aisha Mian, who is a medical doctor who is just going through her GP rotation at the minute. And we're very grateful to have both of them here today. So, medical cannabis law change 2018, specialists can now prescribe. Everybody's happy. The problem has been fixed. Patients are happy, doctors are satisfied, and the frontier is growing. Harry, is that the case?
No, not really. So I think when we look at the number of people who are able to access medicinal cannabis through the routes that are set out, it's a lot lower than we'd expect. And a lot of patients are frustrated by the process, and there are a number of barriers for them. So I'd say there's still a long way to go for medicinal cannabis to have the general the general level of access that I think we'd all see as being sort of appropriate.
Yeah, I think I would agree with that. I think we all thought that when the law changed, that would be the panacea. And everyone would be happy. Obviously, that's not the case, and we know that perhaps only a few thousand patients so far in total have received an appropriate medical cannabis prescription through a specialist. Dr. Aisha, could you just explain to us, just for those who aren't aware, what's the current framework? So who can prescribe, who can't prescribe? How does that work?
Okay, so this is where the biggest challenge lies. I think, number one, it's important to state that when a law changes, obviously, I think people were expecting a law changes and there's going to be everything else in place to be able to mean that everyone is going to be able to have access to it. But it's all dependent on who's making the laws and everything else that comes around it. So there was a big problem in terms of lack of education, I guess, amongst doctors. Now, the way it works at the moment is so cannabis is a controlled drug, and it has been moved from the scheduling system that we have in the UK from 1 to 2. And that means that if you are a doctor on a specialist register, then only you can prescribe. And even then, there's a lot of caveats to that. So only if it's prescribed as, it won't be first line as an option. Being a specialist means you have to go through many, many years of training, and you have picked a certain specialty, a medical specialty or whatever it is. And that specialty has to be familiar enough with the condition that you're going to be treating that also has some place for medical cannabis to be used. And even there's a problem, because the neurologist, for example, epilepsy probably has like a fairly decent amount of evidence behind it, but most neurologists still wouldn't really consider cannabis as a valid therapeutic option, even though there's nice guidelines. So there's still a lot of issues, even in terms of doctors understanding what are the legal barriers, what can they prescribe, what can't they prescribe, and if anything, doctors are going to err on the side of caution. So it's really just a very select amount of people that can potentially prescribe at the moment, not GPs at all.
I think it's useful to, as an illustrative point. So I started medical school in 2002, back in the day, and this month I am joining the specialist register. So I've finished my specialist training this month, and it's been, and it's now 2020. Well, doesn't feel like, just glad to get over the line. But I've had no breaks in my training, and so it's been almost 20 years to get onto the specialist register. So that in itself gives you an idea of one of the barriers that patients and doctors face if we are going to engender a healthy prescribing relationship between specialists and their patients. There's a big training barrier there. And so, I mean, you say you've just been working in a GP's practice. What's been your experience of patients who feel they may benefit from a cannabis prescription, or doctors who feel that their patients may benefit from a cannabis-based medical product?
So I think, number one, a lot of patients are going to be afraid of admitting use if they do, because to be honest, GPs are really not very aware at all. So they might have patients that come to them and might express some interest in it, but they're really not comfortable in giving any kind of advice. And the default tends to be towards viewing any kind of use of cannabis as problematic use. So it tends to be cut out the cannabis and then we can deal with whatever problem you have, rather than the cannabis is being used partly to relieve the problem that you have. So I think there's a little bit of an issue there. And to be honest, really, like, GPs just do not have any kind of training or understanding. It's really, really intense environment at the moment. We're still quite mostly on telephone consultations. You can barely see the patients a lot of the time at the moment, which is a big problem as well, because it's really difficult to just see how people are. There's a lot more information you get and you need for your clinical assessment by just having a person sitting in front of you, which we're just not having as much at the moment because of Corona and the changes, and things are slowly changing back. But I don't know if this kind of a model, this integrated model, will, like, there's going to be a lot more just telephone consultations rather than in-person consultations. And I think that's dependent on where you are in the country and the kind of practices you're in. And the GPs that I've kind of mentioned it to or spoken to a little bit about it, and I've informed them, even, like, number one, I think a lot of people don't realize that even doctors don't know that it's legal. Even a lot of GPs, they don't know the legal status, so they still think it's completely illegal. It only has harms and there's pretty much no therapeutic benefit. And the other thing is that even if they do know, even if they might be willing to put in some effort and thinking about wanting to learn more because so many patients are coming to them, they don't know where to go. So I have inform them, by the way, there's an e-learning for health module on this, which is this national sort of NHS learning platform that we have for all healthcare professionals in the NHS to access, and people weren't aware that that even exists. And that's what we very regularly use. It's pretty much mandatory for us to use in terms of getting certain learning outcomes from our training, because our training is never ending and we're always having to keep up to date.
Sure.
And the RCGP also actually have a very small module, which I know 1 or 2 doctors that have used it, and they just said they're still very confused. Essentially, it doesn't help them in practice. And in the end, even if you had some basic level of knowledge, what are you then going to advise your patient? There's no the next step in terms of referral or the access, if you even felt confident doing that, which most people just don't.
I think you're right.
So Harry, go ahead.
Yeah, I was going to say, I think you touched on a couple of things there, and also in something you said before, which is the law changed, but actually, you know, a lot of, you know, the specialists are, you know, let's take a pain specialist as an example. You know, it's complex, which is why you have specialists in the first place, and they are aware of the benefits of existing medications. They're also aware of the sort of shortcomings. And what I'm seeing is, more often than not, it's actually a conversation with a patient that's driven them to start looking at this area. And then they've often gone off and you know, done a lot of self-learning. And we obviously will help with the data that we have, where doctors come to us if they want to see something objective that we can offer them, which is good. But they are really a lot of the time doing this on their own. And obviously coronavirus has probably made a lot of things a lot more difficult, taken a focus off it. But so, you know, to then take that and put it in the context of GPs who, you know, we know are under a huge amount of pressure and don't have a lot of time, it is difficult. And I think for patients, you know, I've heard of stories of people speaking to their GP, and you know, different GPs will react differently. I've heard of people who've ended up having, you know, risked their job because the GP's not responded well, and they've, you know, escalated things. And I'm sure, you know, every single case will have its nuances, and the GPs are doing, you know, what they think is the right thing. But there's a real absence of, you know, I guess, guidance, support, and a sort of an approach. And I think the key is, you know, looking at this, you know, holistically. The big problem we've got is there are patients who want to access medicinal cannabis because, you know, the existing options aren't there. A lot of people report that it, you know, it really works. We know that we all know people that have used it for therapeutic reasons, and ultimately, if we're not ready with our healthcare system to sort of work with the patients, we're going to end up with people turning to the black market, and that's potentially a bigger risk, in my opinion, because you don't know what's in the product, it's unregulated, and there's no, you know, yellow flag adverse event system to capture any issues, which, you know, I don't know. I mean, I'm not aware of many drug dealers who are offering a yellow card service as part of the service. So, you know, I think when we look at it, the sort of lack of engagement could potentially be creating more risk than actually sort of embracing the conversation.
I think that's excellent. I completely agree. Excellent point. I think that there is a quandary because the classical model of healthcare delivery in the UK is that the patient comes to the doctor, whether it be a specialist or a GP, with a problem, and the specialist or the GP has the kind of the training and the solutions and the options, and they can talk through the options together. But we're in this difficult situation where patients are going to their GP with a problem and they have already researched a solution. And the GP or the specialist is unable to say whether that solution is good or bad. And the default will always be, I don't know. I think that could be harmful. And furthermore, GPs have a huge workload. And the whole health service internationally has been under stress recently, but GPs classically have a very high clinical workload. They very much get the thick end of the wedge. And also, they have no mechanism, even if they did want to prescribe these medicines, even if they had the training and the backup and the clinical know-how and the efficacy knowledge, they don't have the structural legislation to to fulfill these prescriptions even if they wanted to. And so I guess the whole point of this conversation, as you've both alluded to, is to, if there were to be a change and GPs were to prescribe, what would that look like? And what do we think would be the risks and the benefits of that? Aisha, you've just been in a practice at the coalface. What do you think?
I think there's still some way to go in terms of actually giving GPs a bit more confidence with the knowledge base to be able to prescribe this. Because Harry, you were right in terms of saying we need to take a holistic approach towards this. And the thing is you literally just do not have time. You have barely 10 minutes. And, you know, I was starting off with much longer consultations. And even then my consultations were ending up to be so long because, especially with the coronavirus, there's been such a backlog of being able to manage so many different conditions that people are really quite desperate at this point in time. So in terms of like, how could we think about like GPs wanting to prescribe this? Other than the education, we just need a lot more other reforms to happen in the system to allow the time, allow the space for them to be able to even think about prescribing. And I think from this recent report, the Primary Care Cannabis Clinicians Network, most GPs still said, I think it was almost 75%, I think they said that they still don't think that GPs should prescribe.
Well, okay, just talk us through the ins and outs of that report, because I think some of our listeners may not have had the benefit of hearing that, because it's only just been released, only just been published.
So
what is it?
A survey. This is a survey of roughly about 1,000 GPs that's come out recently to try and get a bit of an idea of their knowledge and attitudes towards medical cannabis. And it's quite clear that, number one, most doctors do not have any knowledge about it.
We're talking about GPs specifically.
Yeah, sorry, GPs. So most GPs don't have the knowledge basis for it and are not willing to comment on any kind of, do we think it's efficacious and this, that, or the other. And on top of that, I think there's still a decent amount that don't even acknowledge there's any therapeutic value to it. And it seems to me from the data that the doctors are more inclined to consider it as something problematic than not. So there's quite a bit of an educational gap there. But it's interesting because there isn't the education there, and the GPs acknowledge there isn't the education there and the understanding there, but there is actually a very negative, already pre-existing bias towards any kind of opinion that might be left over. So it's sort of not, okay, I don't know about it, so I can't give an opinion. It's, I don't know about it and I think it's wrong or it's bad.
It's interesting because I think I agree with you that actually the overwhelming thing, out of it was we don't know enough. There were, I can't remember the exact number, but there was certainly a relevant number that said they would support it. But actually, if we look at countries like the Netherlands, for example, I think only about 20% of GPs use medicinal cannabis in their practice there. And obviously we all think about the Netherlands as being quite welcoming of cannabis generally. But putting that to one side, I live in Hackney, and you can't walk down the street without smelling cannabis. And if I were a GP, medicinal or not, I think I'd like to know what the risk factors are and which drugs I should be really cautious of, because the view we have is that medicinal cannabis is on the whole very low risk, but there are certain circumstances where drug interactions would concern us. And I think it's really important that GPs have that information, because if a society is increasing prevalence of illicit use even, then I think it would be good for them to have a better and more balanced understanding, so that they can make better informed decisions even outside of talking about prescribing medicinal cannabis.
I think that sorry. Aisha.
I was just going to really quickly make that point, that I think what I'm trying to say is the viewpoint or the approach that comes from doctors in general is that it's just harmful, that's the foundation of where we're coming from. So it's not even necessarily even thinking about any potential benefits. The automatic default opinion is that it's harmful and there is no valid therapeutic use.
Well, the one point I would make is that if you look at the Danish pilot, which has been running for a few years now, obviously, so as you both know, Denmark's very conservative legislation, and they put in place sort of a cannabinoid medicine pilot where a number of clinicians could prescribe, didn't have to be specialists. And what they have found from some of the early data is that although initially there was skepticism amongst clinicians, there were these cultural barriers, which you are describing in the UK, that actually with the legislative change and the right support, that actually those cultural barriers and those knowledge barriers were overcome purely because of a legislative change. And so the medical system adapted to the legal landscape. And I wonder if we were to have a similar pilot in the UK, if these cultural barriers that you describe and these educational barriers actually would be overcome purely by the fact that we are running a pilot, that it's endorsed nationally, that it's backed up by the health service and government. And I wonder if that would be the key to breaking down some of these barriers that we've been describing.
That's really interesting. And I think there are a number of different pilot models, that we can see in Europe. And I think the thing that we're often hesitant about when we're thinking about this is the UK's health system is so unique that you can't just take exactly what someone else has done and apply it. But I guess the key takeaway is in these pilots, people are trying to create a low risk environment for this to be tried and tested. And I think, I haven't worked in a GP surgery, and I haven't been a specialist, so I can't judge what that must be like. And ultimately, I think it's, these are tools for healthcare professionals. And I think the only way we can really assess what the impact could be and what the attitudes would be is by asking people and by, potentially trialing it. And I think if the biggest concern is risk and harm, which I think it's, it sounds like it is, and there are perceptions of it, then a pilot could be a really interesting way of ensuring patient safety, ensuring proper oversight, and actually, really looking at it properly and thoroughly, so that nobody feels as if there's a slapdash decision being made, because ultimately the NHS is there to look after people and not create harm.
Mm-hmm. And I think it's also worth underlining that I think although there is frequently in these discussions, it's very easy to doctor bash and say, they're not educated enough. But I think GPs just want their patients to get better. They want to provide a good health service to the local community. And I think if we are able to endorse a safe prescribing environment that is well supported, you do wonder what cultural and educational barriers could be overcome. Yeah. Isha, if there were to be a law change, let's say, or a pilot within your practice, what do you think the response would be if it were supported by, say, a government body and was done in an academic way in order to generate data? What would be the visceral response from your colleagues?
I think as long as there's as long as the authoritative resources give their backing. So like if they knew that the RCGP, if they knew that the BMA...
Just for our listeners, because I mean, what is the RCGP?
So the RCGP is the Royal College of General Practitioners. So it's like the membership body for all of the GPs. The BMA is sort of like the doctors' union. If NHS England or Health Education England, so there's many different sort of like bodies in the NHS that doctors look to for the guidance and support. And as long as there's sort of validation, or if they sort of give the green light to these sorts of things, and that's easily documented and that's well publicized, I think doctors wouldn't be afraid to go ahead and start to explore like the evidence that can be brought about from any kind of a pilot scheme or any kind of research that might go about. The main thing is doctors themselves, especially in this corona times. I don't know if people quite understand, like, everything in medicine has changed a lot, and there is a lot more risk just in general because we've changed the way we've practiced so dramatically. And the workload is insane now, so it's just making sure you're not missing things and making sure we're having enough clear guidance to be able to go ahead and make the next steps and actually do our jobs. And right now, a lot of that is still being worked out, and it's changing quite a lot. So as long as there's support from sort of like the doctors' unions and the governing bodies, I think that there would be support for it.
So it's clarity that you're seeking, essentially. And Harry, what would be the response, do you think, from an industry point of view, sort of risks and benefits, opportunities and hazards?
Interesting. It's an interesting question. I think one of the, when I look at what we're talking about here, I was around when the law changed, and I remember some of my colleagues were. You start looking, you start noticing things as the law's changing, and we'd go into NHS practices and see signs up saying, "Don't ask us about medicinal cannabis. We're not going to help you out." So the last thing we want to do as an industry is create problems for healthcare professionals, I think. So I think everything that Aisha's mentioned there about workload, that's something that we as an industry care about. And if we don't care about it, then I think we're in the wrong industry, to be honest. So for us, I think we'd want to make sure that the healthcare professionals are able to sort of own it and make it their own. Because I think, the industry, as you said, it can be easy to doctor bash, but actually, we're here to serve patients. The doctors are there to serve patients, and we need to fit in with them. So I think that would be a real concern. I think an opportunity would be to take the conversation away from, cannabis is terrible. No, it's not. It's great, and it's very binary. And I think it would enable a much more a much better informed conversation for everybody, and provide an environment for all the stakeholders to look at it and say, well, actually, for these patients, it can have some benefit. And actually, where are the risks for us? So what are the red flags that we need to watch out for and make sure that we stay away from? And I think that could create a much better environment for everybody. And when I'd look at it, I'd say that the goal would be that for those healthcare professionals that do want, they are interested and they do want to consider this, they've got some clarity as to how they might go about it, what the process is, what it means for them professionally, what the rules are, and just make sure that they've got sort of appropriate support. And I think we'll only get that through listening and through sort of working in a pilot. So it's not something that I think we'd rush into, but I'd really welcome it, I think.
Lovely. Closing. Dr. Aisha, any closing comments from yourself?
Well, there was just two sort of potential solutions I wanted to think about, like at least opening it up to everyone to think about if they want to start moving things forward when it comes to education, because we talk about it quite broadly, but we don't necessarily think about what specifically we would want to mention or why. The why is always the thing that I think gets missed out a lot. And when we don't address the why, everyone is left confused. So I think number one, to recognize that this is actually sort of backed up in this PCC and the GP survey as well. So essentially, most doctors, not just GPs actually, they said in GPs too, but most doctors do not have time for very extended webinars and courses, discussions, unless it's very much relevant to their practice and they're getting a lot more out of it. So really easy to use, like summary sheets and condensed information that's really relevant to what a doctor would need to know and what they can also apply in practice is really, really useful. I think they will really respond to that. It doesn't have to have the whole world's worth of information and all of the nuances. It can signpost, but having like very short and easy to understand fact sheets is a really good starting point in terms of educational materials, and having things like this in the avenues that doctors would go to regularly to search. Whenever I'm with a patient and I'm stuck, like, I know that there's a few different resources that I will go to check out what is the main things that I need to be asking, and the main things that I need to be concerned about and, watching out for. And this is how I'm gonna it's going to guide me managing the patient. So those kind of sources are good places to start in terms of where you would want to provide the education. And the other thing as well, when we're talking about the education too, is trying to give a little bit of a background context too. So just explaining a little bit about why we are in this situation. Why is it that there is the patients think that it's so useful, and what kind of evidence they might be looking at to guide them coming to you as a medical practitioner to actually advise them on. So that will mean that you'll have to start to address like the public health issues, a little bit more about the legislation, because we're not really taught a lot about the way even the NHS works, or about the laws or anything like that. So just some very simple information about why is it that the laws are like this? Why is it that it's only in 2018 that we have changed things? And why is it that prescriptions are still not really very available? And addressing some of the key socio-political and historical context to this, which is often either glazed over or just not included at all, I think is a really important grounding for us to be able to then sort of deal with some of this confusion about why some people think it's useful and why some people don't, and how this binary has even come about.
But I think, but I think you're absolutely right. Simple fact sheets are super helpful, but it's also, I think having more available for doctors to dig into if they want to. I imagine.
Yeah, at the end, it would be like signposting, but something simple for them to at least get into it that's relevant to what they're going to want to what they're going to want to know about just straight away.
Interesting.
Great, closing comments. I think we're slowly, slightly approaching the end of our time slot. Any last comments? Any short comments?
Well, look, I think from my perspective, because of the nature of my job and working in the industry, whenever anybody is one of their family members is unfortunately really sick or facing something, I get a lot of questions and I get a lot of comments, and people are really interested. Patients don't know enough. The quality of the information that's available outside of the healthcare system is variable. I'd say there's some really good stuff. There's some stuff that I think we would question from a scientific basis. And, I think if we ignore it, we're just going to compound a potential problem where there is a risk. And I think if we don't, and we work with the healthcare professionals who are interested and see the benefit, we're going to be in a much better place for patients in the end.
And Dr. Mian?
I'm overall quite positive about everything. So I think with some good educational information, if we're having sort of a multidisciplinary and a holistic approach, and we actually include all stakeholders in the process, I think that's more towards the future of the way the NHS is developing, and the future of medicine anyway is a lot more integrated. So I think if we have a bit more of a longer term thinking in mind, knowing that there's not a quick fix to this, but making sure that we can include all the relevant players, all the relevant stakeholders, then I think if we have this combined approach, I think that's what's going to make this successful and minimize any of the harms, because we want to practice harm reduction in the process and maximize any potential benefit that we can get out of this.
And I think we're all in agreement that what we're really after is safe and effective healthcare for patients, and that's what we're all.
Yeah, absolutely.
So Dr. Aisha Mian, who's just finished Nights Understand, and Harry Guliani from Columbia Care, thank you very much for your time. We shall see you again. Thank you very much.